So my fascination with aortic root aneurysm as a phenotype dates back about 30 years. Aortic aneurysm in general accounts for the death of approximately 1 to 2% of people in industrialized countries. In various genetic presentations of aortic aneurysm, the most common finding is dramatic dilatation of the root of the aorta at the level of the sinuses of Valsalva, with rapid taper to a more normal aortic dimension in the more distal ascending aorta. Common presentations of aortic aneurysm have been difficult to model and study due to complex inheritance, incomplete penetrance, and the lack of foundational principles that would guide mechanistic analyses. So we made the very deliberate decision to initially focus on a rare Mendelian, but therefore tractable presentation of aortic aneurysm called Marfan syndrome. As many of you know, Marfan syndrome is a systemic disorder of connective tissue with dominant inheritance and a prevalence of about 1 in 5,000. The syndrome is highly variable with cardinal features in the ocular, skeletal, and cardiovascular systems, including dislocation of the ocular lens and overgrowth of the long bones, but most importantly, progressive dilatation of the root of the aorta that will lead to aortic tear, rupture, and early death if left untreated. In 1991, we used a traditional positional candidate approach to show that mutations causing Marfan syndrome occur in the gene that encodes the connective tissue protein fibrillin-1. So what did we know about fibrillin-1? We knew that monomers aggregate to form complex extracellular structures called microfibrils, and that microfibrils cluster around the maturing ends of an elastic fiber during embryonic growth. This simple spatial and temporal relationship led to the firm belief that you need a lattice of microfibrils to make an elastic fiber during embryogenesis. And if you think about it, this really boded poorly for the development of treatments. It suggested that children with Marfan syndrome are born with inadequate elastic fibers, and that they therefore have an obligate structural predisposition for their tissues to fail later in life, that there's nothing you could do after birth. So I can remember the day and even the moment walking into a patient room, seeing fingers just like these and thinking, this just doesn't make sense. Why would weakness of the tissues cause overgrowth of the bones? For that matter, why would weakness of the tissues cause the craniofacial manifestations of Marfan syndrome, like a long and narrow face, downward slanting palpebral fissures, and a small and receding chin? Why would weakness of the tissues cause the low muscle mass and low fat stores that are so characteristic of this condition? Each of these findings was more suggestive of altered cellular performance. So progress is made when we made mouse models of Marfan syndrome and examined the lung. What we knew is that some patients with Marfan syndrome develop a picture consistent with progressive emphysema that can result in pneumothorax or respiratory insufficiency. When we were about to look at the lungs of the mice with Marfan syndrome, what we expected to see was normal lungs at birth and then gradual tissue destruction and inflammation over time as force acted upon a structurally deficient tissue. But instead, we saw homogeneous widening of the distal air spaces right from the time of birth, in fact, beginning prenatally, without any evidence of tissue destruction or inflammation. This was not consistent with a destructive emphysema, but rather was more suggestive of a developmental defect, a developmental emphysema. So this begged the question, how might deficiency of a structural connective tissue protein influence developmental events such as lung septation? More progress came when we asked a very simple question. We asked, what other proteins do the fibrillin proteins look like? And the answer was that they are very structurally similar to a family of proteins called the latent transforming growth factor beta binding proteins, or LTBPs. The multipotential growth factor TGF-beta, which indeed does instruct cells how to behave during development, is secreted from the cell in the context of a large latent complex that includes a dimer of its processed N-terminal propeptide called latency-associated peptide, and one of 3 of these LTBP molecules. So we reason that fibrillins interact with each other. Fibrillins look like LTBPs. Perhaps fibrillin in the extracellular space is somehow influencing the bioavailability or activity of TGF-beta. So to test this, we made a reporter mouse cell line that expresses green fluorescent protein from a TGF-beta responsive promoter element. And that we introduced this into our mouse models. So here I'm showing you the amount of signal in a non-transgenic animal that lacks this reporter allele. So this represents autofluorescence of the tissues. If you introduce the reporter allele and have 2 normal copies of the fibrillin-1 gene, you see this level of physiologic TGF-beta signaling. If you disrupt one fibrillin-1 allele, you see a 4-fold increase. And if you disrupt both fibrillin-1 alleles, you see a 40-fold increase. So now we had a fibrillin deficiency, we had too much TGF-beta activity, we had a lung phenotype, but not yet a cause and effect relationship. So to address this, we asked what would happen in fibrillin-1 deficient mice if we injected a pan-specific TGF-beta neutralizing antibody. They're still missing fibrillin-1, but we were wondering what would happen if we blocked downstream effects on TGF-beta signaling. You can see that if we gave irrelevant IgG, we still see this very dramatic distal alveolar phenotype with widening and a long distance between lung walls called the linear intercept. If we gave a low dose of TGF-beta neutralizing antibody, we saw substantial improvement. And if we gave a high dose of TGF-beta neutralizing antibody, the degree of lung septation was essentially equivalent to that observed in wild-type animals. So this really suggested that TGF-beta was contributing to this aspect of the Marfan phenotype. Now, in a large body of work performed by my lab and others, it was indeed confirmed that the large latent complex of TGF-beta directly interacts with fibrillin-1 due to a biochemical association between LTBPs and fibrillins. That in the microfibrillar deficiency state, as in Marfan syndrome, there's inadequate matrix sequestration of latent TGF-beta. And on that basis, promiscuous activation of the cytokine that can then go on to interact with its cell surface receptor and set in motion an intracellular signaling cascade that includes phosphorylation of SMAD2 or SMAD3 that then partner with SMAD4, translocate to the nucleus, and drive TGF-beta transcriptional responses. And most importantly, we could show that this had phenotypic consequence, not only in the lung, but also it was responsible, at least in part, for driving aortic aneurysm, mitral valve thickening and dysfunction, and skeletal muscle myopathy. Because each of these phenotypes could be greatly attenuated or even prevented in Marfan mice by treating with TGF-beta neutralizing antibody. So around 2005, we asked, is there a drug, and even better, an FDA-approved drug, that might mimic some of these protective effects? And our attention turned to a class of medications called angiotensin receptor blockers, with one specific example being losartan, that had been shown to lower blood pressure, something that we think is good for people with aneurysms, but also to antagonize TGF-beta activity in rodent models of chronic kidney disease. So how does losartan work? Angiotensin II signaling, what do I do? So angiotensin signaling through its type 1 receptor can increase the production of TGF-beta ligands, TGF-beta receptor subunits, and also important activators of TGF-beta such as thrombospondin 1. In contrast, angiotensin II signaling through its type 2 receptor can actually antagonize AT1-mediated events. So we reason that selective blockade of the AT1 cascade that occurs with drugs such as losartan would block this culprit side of the pathway and might actually shunt signaling through the protective AT2 cascade. In experiments that I won't have time to share today, we were able to prove that concept. But initially, we went on to do a controlled study of losartan in our mouse model of Marfan syndrome with a focus on aortic root aneurysm. As you can see, placebo-treated Marfan mice show very rapid aortic root growth. If we gave those mice a beta-adrenergic receptor blocker such as propranolol that lowers blood pressure but does not address TGF-beta, we saw a significant but relative reduction in aortic root growth, but no improvement in aortic wall architecture, and a clear signal for residual increased TGF-beta signaling as shown by phosphorylation of SMAD2 within the aortic media. In contrast, no observer could distinguish losartan-treated Marfan mice from their normal or wild-type counterparts by any histologic or functional parameter, including complete normalization of aortic root growth, complete preservation of normal aortic wall architecture, and a clear suppression of abnormal TGF-beta signaling in the aortic media, as shown by immunohistochemistry and also by quantitative Western blot analysis. So at this point, we felt compelled to try this FDA-approved strategy in children with the most severe presentation of Marfan syndrome. These children show unrelenting growth of the aortic root in early childhood, despite maximal treatment with beta blockers and/or ACE inhibitors. These are the aortic root growth curves for the first two such children that we treated with losartan, showing this very evident plateau in aortic root growth. We treated about 20 such children and on average saw a 10-fold reduction in aortic root growth rate while on losartan compared to their performance on prior medical therapy. Now, there have been additional trials of angiotensin receptor blockers in Marfan syndrome. Chu and colleagues in Taiwan performed a study with the identical design as the one I just described, children with very severe Marfan syndrome, and they found about a 9-fold reduction in aortic root growth rate while on losartan. Pease and colleagues in Austria performed a trial in children with a somewhat less severe form of Marfan syndrome and saw a very significant decline in normalized aortic root growth rate on losartan, and also a decline in aortic root Z-score over time, which is essentially the number of standard deviations from normal. Groening and colleagues in the Netherlands performed a trial in adults with Marfan syndrome and found a significant decline in aortic root growth rate after adding losartan. The largest study that was done in this country was by the Pediatric Heart Network. There they compared the performance of beta blockers to that of losartan in children and very young adults with Marfan syndrome. They saw that both treatment arms showed a very slow rate of aortic growth, less than 1 millimeter per year, and a significant and sustained decline in aortic root Z-score over time, but there was no significant difference between the groups. If you look a little more carefully at this study, you see that the trial utilized a very high dose of beta blocker, up to 2 times the upper limit allowed by the FDA for the treatment of hypertension, whereas the losartan dose was capped at the FDA-approved dose for hypertension. And yet you can see that they did indeed achieve a very comparable rate of slow aortic growth. What I think is most notable is that the growth rate in either arm in this trial was less than that previously observed in untreated pediatric patients or in patients treated with more typical atenolol dosing. So I think the bottom line is that both of these treatment strategies show some potential, but there's clearly a need for additional information and for improved protocols. So we've started to address this in our mouse model, where we've now used a full dose titration of both beta blockers and angiotensin receptor blockers. You can see that with significant doses of beta blockers, now up to 20 milligrams per kilo, that we're defining as a medium or moderate dose. We don't yet see a significant decline. There's a trend in the decline of growth rate. But if you use ultra-high dose propranolol, up to 40 milligrams per kilo, you now see a significant reduction. If we used what we consider low-dose losartan in mice, it's 5 milligrams per kilo, we already see a significant difference from baseline. And also, we're seeing at least a trend for improvement over the performance of beta blockers. But here, even after you've maximized hemodynamic effects, at every dose increment, there's a further decline in aortic root growth rate, really suggesting that there is strong potential that this medication is working by a mechanism other than reducing hemodynamic stress. Very recently at the European cardiovascular meetings, there was the report of a trial of a different angiotensin receptor blocker called irbesartan. It was a collaborative study of 22 centers, a very well-performed randomized trial of about 200 patients with Marfan syndrome. Here they used quite aggressive dosing of angiotensin receptor blockers, 150 milligrams in young children who were less than 50 kilograms in weight, or 300 milligrams in those over 50 kilograms. They observed a 30% decline in aortic root growth rate in the irbesartan group as compared to prior medical therapy, with a more rapid decline in aortic root Z-score over time. This proved to have greater benefit in young patients, and there was no signal for interaction between irbesartan or beta blockers, and tolerance was excellent. So suggesting that more aggressive dosing regimens are going to be of benefit. Now, about 10 years ago now, my friend and colleague Bart Loeys and I recognized and described a new aortic aneurysm syndrome that had many features in common with Marfan syndrome, like curvature of the spine, chest wall deformity, long fingers, and aortic root aneurysm. But also some very distinctive, unique features, like hypertelorism, a cleft palate or a bifid uvula in the back of the throat, club foot deformity, certain forms of congenital heart disease. Most importantly, these children have a very aggressive diffuse vasculopathy that includes tortuosity of neck vessels throughout the body, often prominently in the neck. Also aneurysms not just at the aortic root, but at other locations throughout the circulation here of the proximal subclavian artery. These aneurysms tend to rupture at young ages and small dimensions compared to Marfan syndrome. And this condition is now referred to as Loeys-Dietz syndrome. We currently have had the privilege of caring for over 300 families with this condition, and we know of many, many other additional patients throughout the world. So based upon what we had learned about Marfan syndrome, we reasoned that this condition would also relate to TGF-beta signaling. And in fact, we now know 6 genes that can cause Loeys-Dietz syndrome, all directly involved in the TGF-beta signaling pathway. These genes encode either TGF-beta 2 or TGF-beta 3, either subunit of the TGF-beta receptor, or SMAD2 or SMAD3, the direct signaling intermediates for TGF-beta. We also found the gene for a very related condition that's called Sprintzen-Goldberg syndrome. This condition shows virtually every craniofacial, skeletal, and cardiovascular manifestation of Marfan syndrome and Loeys-Dietz syndrome, with the added finding of intellectual disability. And we were able to show that this is caused by primary mutations in the Sloan-Kettering Institute proto-oncogene SKI that encodes a prototypical repressor of the TGF-beta transcriptional response. So when TGF-beta signaling is high, SKI is recruited to the site of transcription of target genes and turns off target gene expression. We went on to make mouse models of Loeys-Dietz syndrome by creating knock-in mutations in the TGF-beta receptor genes. You can see that these mice show a clear signature for increased TGF-beta signaling in the aortic root, but not in other aortic segments that are not showing the predisposition for aortic enlargement. We found, as in Marfan syndrome, that losartan is remarkably protective in preventing aortic root growth, as opposed to propranolol, which in this context, even at high dosing, did not show any protection, and that losartan also preserved aortic wall architecture in Loeys-Dietz syndrome. We went on to make knock-in mouse models of Sprintzen-Goldberg syndrome, and as expected, found that these mice with mutations in SKI showed dramatic aortic root growth and aneurysm formation with death due to dissection if left untreated. We found that, as expected, all the TGF-beta target genes that we looked at in the Sprintzen-Goldberg model show excessive expression. You've lost a repressor of target gene expression. We can show that Sprintzen-Goldberg mice are remarkably receptive to treatment with losartan with complete suppression of abnormal aortic growth and also preservation of aortic wall architecture. So I think in sum, these data suggest a broadly relevant mechanism for aortic root aneurysm, that is increased TGF-beta treatment, but also a broadly relevant treatment strategy, that is AT1 blockade. So up until this point, all of my comments have focused on the SMAD-dependent, so-called canonical TGF-beta signaling cascade. But it's also known that ligand-activated TGF-beta receptors can support so-called non-canonical cascades, prominently including the mitogen-activated protein kinases ERK, J and K, and P38. So we decided to see if any of these are also contributing to disease progression. When we looked at the aortic wall of our knock-in Marfan mouse compared to wild-type littermates, we saw this increase in SMAD signal as we had described before, but an even more dramatic increase in the activation of the ERK signaling cascade as shown by excessive phosphorylation compared to control mice. We didn't know if this was a marker of disease or actually a driver of disease. So to address this, we showed that ERK activation in Marfan syndrome is TGF-beta dependent. If you treat with a TGF-beta neutralizing antibody, you suppress the excessive ERK activation. We went on to gain access to an orally bioavailable, highly selective, potent MEK inhibitor that prevents phosphorylation of ERK called RDEA-119. We could show that this is every bit as good as losartan in suppressing abnormal aortic growth, and indeed has the desired effect of suppressing ERK activation in the aortic wall without any effect on any of the other signaling cascades under consideration. So we had a new foundation. ERK is bad, and we wondered if we could use this to address any underserved or particularly vulnerable patient populations. And one such group is women with Marfan syndrome who choose to become pregnant. These women show an alarming rate of aortic tear in association with pregnancy that has historically been attributed to the hemodynamic stress that attends pregnancy and delivery. But it seemed odd that the vast majority of events were occurring weeks to months after delivery, and that this risk was not modified by antihypertensive agents or cesarean section. So we asked what initiates toward the end of pregnancy is maintained after delivery and might synergize with some of these signaling events described for aneurysm and dissection. The hypothesis that we came to was the hormone oxytocin, which is needed to initiate uterine contraction and milk letdown. Its release peaks at the end of pregnancy and is sustained during breastfeeding. And the receptor for oxytocin is upregulated in the aorta in response to both estrogen and pregnancy. We were particularly intrigued when we learned that the mechanism by which oxytocin stimulates peripheral tissues is through ERK activation. So we went on to use a mouse model of Marfan syndrome that was developed by my colleague Francesco Ramirez at Mount Sinai. This mouse model essentially shows 100% death due to aortic dissection within 3 weeks after delivery, always after delivery, and really quite remarkable penetrance of this phenotype. This is in dramatic contrast to Marfan mice that were never pregnant, shown in black, and to male Marfan mice shown in red. So we next asked what would happen if we allowed these mice to become pregnant, allowed them to deliver, but simply took the pups away right after birth to prevent lactation-induced oxytocin release. And the answer was that simple manipulation transitions survival from near 0% all the way up to 70% just by taking the pups away. The final question is what would happen if we treated these mice with an oxytocin receptor blocker, and that was sufficient to lead to essentially 100% survival in this Marfan mouse model despite delivery. We went on to show that outcome correlates perfectly with the level of ERK activation in the aortic wall, which is high in Marfan syndrome, greatly elevated during lactation, and brought back down to normal by avoiding lactation or treatment with an oxytocin receptor blocker. We also went on to test an FDA-approved ERK inhibitor called trametinib, and we're able to show that this is very potent at preventing pregnancy-associated aortic dissection. So all news isn't good news. We decided to look at what the consequences of using multiple treatments that were considered safe for use in people with Marfan syndrome. One such treatment is the use of calcium channel blockers that were considered second-line antihypertensive agents for patients with Marfan syndrome who couldn't tolerate beta blockers, for example, those with depression or asthma. We were initially hopeful. It was described that calcium channel blockers such as amlodipine could reverse ERK activation in hypertensive rats, and that other calcium channel blockers could reduce ERK activation in synergy with angiotensin receptor blockers. So we had high hope for this strategy. We applied a considerable dose of amlodipine and followed these mice with echocardiography. So here I'm showing you an echocardiogram on mice. This is a wild-type mouse. The yellow arrowheads are showing you the aortic root. We're in systole. You can see the aortic valve is open. The red arrowheads are showing you the more distal ascending aorta. In our Marfan mouse model, you can see that there is dilatation at the root of the aorta with a normal dimension of the more distal ascending aorta. In normal mice, given calcium channel blockers, we didn't see much. Perhaps the ascending measurement was looking slightly generous, but in virtually 100% of the Marfan mice treated with calcium channel blocker, we saw the hyperacute formation of giant ascending aortic aneurysms, literally tripling their aorta, tripling the aortic size within about 3 weeks, with death due to aortic dissection within about 4 to 5 weeks. Here I'm showing you the heart and aortic arch of a wild-type animal. In our Marfan mice, you can see that there is a flare at the base of the aorta. In wild-type mice, given amlodipine, we're not seeing much difference. But in virtually every Marfan mouse, given calcium channel blockers, these giant ascending aortic aneurysms. There was some acceleration of aortic root growth in response to amlodipine, but this dramatic increase in more distal ascending aortic growth Interestingly, this is an aortic segment that's normally spared in Marfan syndrome. We know that this is not simply an artifact due to the very high dose of calcium channel blocker that was being used. If we ratcheted down the dose to 3 milligrams per kilo, you see the identical acceleration of aortic root growth and more distal ascending aortic growth. Here's the synthetic lethality that we observe in Marfan mice given calcium channel blockers, with death due to aortic rupture starting at about 4 weeks after initiating treatment. We tried all different classes of calcium channel blockers and showed that they caused essentially the same phenomenon, here showing the results using the non-dihydropyridine calcium channel blocker verapamil. So contrary to prediction, we found that calcium channel blockers were not decreasing, but actually enhancing both the canonical SMAD and non-canonical ERK cascades in the aortic wall of Marfan mice. We could again say that ERK is the culprit. If we gave calcium channel blockers and also the MEK inhibitor RDEA119, we were able to prevent this deleterious gene by environment interaction. And you can see that we were indeed achieving the desired result of normalizing the excessive ERK activation. Here I'm showing you the very dramatic protective effect of the ERK inhibitor. What's notable is we not only fail to see aneurysms, but that the aortic wall architecture is dramatically preserved. And in the presence of ERK inhibitor, it doesn't simply revert back to the state of Marfan syndrome without calcium channel blocker, but actually looks considerably like wild-type animals. So it really is suggesting to us that ERK is the dominant driver of disease. You see this very intense fibroproliferative response within the aortic wall of Marfan mice treated with calcium channel blockers, and again, an appearance that is essentially indistinguishable from normal upon using ERK inhibitors. So we had a challenge. We could tie together by looking in the literature angiotensin signaling, angiotensin II type 1 receptor signaling, TGF-beta, and ERK, but the question is, where do calcium channel blockers fit into this scheme? In further review of the literature, we found that each of these cascades can influence the activation of phospholipase C, that calcium channel blockers also have the ability to enhance PLC activation, and that then through an IP3 protein kinase C axis could culminate in ERK activation. In keeping with this model, we do see excessive phospholipase C activation in Marfan mice treated with calcium channel blockers. And also, informatively, the PKC inhibitor enzastaurin is able to achieve a significant reduction in aortic root growth rate in these mice. At this point, we wanted to know, have we just learned something about this artificial circumstance of Marfan mice treated with calcium channel blockers, or perhaps have we learned something fundamental about the disease process? So to test this, we tried enzastaurin in Marfan mice that had not received calcium channel blockers and found this quite dramatic reduction in aortic root growth rate. In fact, aortas that showed a significant decline in dimension over time in association with clear prevention of protein kinase C and ERK activation in the aortic wall. Also, based upon this scheme, we reasoned that the drug hydralazine that works at least in part by reducing IP3-mediated calcium release, and on that basis PKC activation, should also be protective. This indeed turned out to be true, and indeed had the signaling consequences that we predicted with a decrease in PKC and ERK activation. This was important because hydralazine, unlike angiotensin receptor blockers, are safe to use during pregnancy. Hydralazine is also FDA approved, and you can see that it leads to dramatic protection against pregnancy-associated aortic dissection in this model. So we now have a mature pathogenic sequence for aneurysm in this Marfan mouse model. The reason why losartan works seems obvious because it's working up high in this cascade. Indeed, losartan is able to prevent the calcium channel blocker mediated aggravation of the phenotype and also blunts both PKC and ERK activation. We poked and prodded this axis in every way that we can imagine. Oxytocin, prominently through the oxytocin receptor, works at the level of PLC activation. You know, we made 3 propagations that were predicted to worsen aneurysm that indeed had that effect, and 6 provocations that were predicted to prevent aneurysm, and indeed we saw the expected beneficial effects. So this is all on the basis of work in animal models. What about people with Marfan syndrome? So we partnered with a GenTAC database that's collecting information on people with genetic presentations of aortic root aneurysm, prominently including Marfan syndrome. We found that people who were receiving calcium channel blockers at the time of enrollment in this registry had about a 13-fold relative risk of having aortic dissection during the follow-up period compared to those not receiving calcium channel blockers. This elevated risk among people taking calcium channel blockers for aortic dissection was also evident in other presentations of thoracic aortic aneurysm. As you might expect, folks with Marfan syndrome taking calcium channel blockers also had an increased risk of aortic surgery during the follow-up period. So up until this point, all the work has been very hypothesis constrained. We'd make a foundation observation, then we'd predict the consequences of that foundation and test it. But we wondered whether we could use a non-hypothesis constrained discovery-based method to learn something new about Marfan syndrome. Over the course of many years of caring for patients, we identified 5 exceptional families with Marfan syndrome who showed discrete intrafamilial variability in phenotypic severity. By that I mean that half the mutation carriers in these families, shown in black, showed classic severe Marfan syndrome with huge aortas and early aortic surgery or aortic tear. But another sizable group of people in the same families with the same mutation were remarkably protected from aneurysm with completely normal aortas even in their 50s, 60s, and 70s. So we decided to use linkage analysis to now not map the Marfan gene, but rather map the modifier. Fortunately, there was no locus heterogeneity, and all families showed segregation of markers on human chromosome 6 in association with protection from the aneurysm phenotype. There are 32 genes in this critical interval, but one of them jumped out as a potential candidate. It's MAP3K4 that encodes a mitogen-activated protein kinase, the kind of enzyme that activates ERK and P38. We found that in severe Marfan patients, the level of expression of this gene was significantly higher than in Marfan patients that had the more mild disease. We didn't have the opportunity to go find more of these truly exceptional families, so we returned to our Marfan mice and introduced haploinsufficiency for the MAP3K4 gene, just disrupted 1 copy, and found that this was sufficient to normalize aortic growth and also to suppress the abnormal the abnormal ERK and P38 activation seen in the aortic wall of our mouse model. We also realized that there was a huge background difference in our mouse model. So if you put our Marfan mutation on an ultra-pure black 6 strain, the aneurysms rapidly disappeared. You could still see very subtle statistical evidence for aneurysm, but the aortic contour looked absolutely normal by echocardiography, and these mice never showed death due to aortic dissection, shown in red. If you put the same mutation on the ultra-pure 129 background, you see this very dramatic increase in aortic root growth, here shown by these veritably huge aortic root aneurysms and early death due to aortic dissection, as shown in blue. There's no difference in heart rate or blood pressure between the strains, so it's not simply a hemodynamic issue. We found that the lung disease is more severe on the 129 background as compared to the black 6 background, that the skeletal disease, the degree of kyphotic curvature of the spine, is also more severe in the 129 background, and that the signaling abnormalities that we've been thinking about are all greatly exaggerated on the predisposed 129 background, including the excessive SMAD activation, PKC, and ERK activation that we've so definitively linked to disease pathogenesis. So now we found that the predisposition that was present on the 129 background remains dramatically responsive to losartan and also remains responsive to the ERK inhibitor. So everything that we had found so far seems to be relevant to this exaggeration on the 129 background. We simply crossed the two strains, selected for mice with huge aneurysms, selected for mice with very small aneurysms, and did a non-parametric linkage analysis. And we're able to show that virtually all of the variation between the black 6 and 129 strains could be accounted for by only two loci, on mouse chromosome 5 and mouse chromosome 11. There was also evidence for gene-gene interaction or epistasis between these loci. When they were combined, the LOD score shot up to 12.8. So again, there were a number of genes in these intervals. Our attention turned to a specific gene on mouse chromosome 5 that's called MMP17. It's known to regulate ERK activation, and it has a stop-loss mutation that differentiates the black 6 and 129 strain. On mouse chromosome 11, there is the MAP2K6 gene that again activates mitogen-activated protein kinases, and it's activated by MAP3K4, the human modifier. So it seems by looking at modification between two different species, we perhaps have identified a pathway of modification. Again, there's a very significant predicted deleterious amino acid substitution that differentiates the black 6 and 129 strains. So here what we did is we took those mixed mice and we binned them by virtue of how many wild type 129 alleles they have at both MAP2K6 and MMP17. As an alternative, we introduced null alleles for both MAP2K6 and MMP17, true knockout alleles. We found that in the mixed background, if you selected for null alleles at both of these loci, those animals behaved exactly like the protected black 6 background. If you only selected for homozygosity for normal 129 alleles at both loci, essentially those mice behaved exactly like the predisposed 129 background. We went on to look at signaling and found that knocking out only MAP2K6 and MMP17 can normalize all of the signaling abnormalities within the aortic wall, looking much more like protected black 6 background than the predisposed 129 background. Again, if you only knocked out MMP17, you saw an intermediate result with regard to signaling, attesting to the fact that it's both of these genes that are contributing to the protection. Now, MMP17 is a really interesting molecule. It's a GPI-anchored form of a matrix metalloproteinase. It has direct protease activity, but also has activities independent of its protease domain. One such activity is the ability to transactivate the EGF receptor, even in the absence of the EGF ligand. And this in turn sets in motion the PLC, IP3, PKC, ERK axis. So we went on to ask whether there is increased EGFR activity on the 129 background with the active allele, and the answer was clearly yes. Now we found that only inhibiting or knocking out MMP17 is sufficient to fully normalize the EGFR activity in our Marfan mouse model, and that an FDA-approved EGFR antagonist called erlotinib is able to protect mice from aortic aneurysm and indeed achieves the expected signaling abnormality rescue. So in conclusion, I think that taken together, these data suggest that natural genetic variation that attenuates TGF-beta or ERK activation in both people and mice with Marfan syndrome has the ability to protect from vascular disease. And we strongly believe that pharmacologic agents that leverage nature's modification strategies represent novel and potentially potent therapeutic options for the care of people with Marfan syndrome. Indeed, we're currently partnering with Big Pharma to develop both MMP17 and MAP3K4 antagonists. As a very brief end to the talk, there is another connective tissue disorder that we're very invested in called vascular Ehlers-Danlos syndrome. It's perhaps the most desperate connective tissue condition. These people have a deficiency of type 3 collagen. This leads to a characteristic facial appearance, to very thin skin with easily visible underlying veins, to a predisposition for hollow organ rupture. You can see this individual has a scar from an abdominal surgery. But to aneurysms, dissections, and ruptures throughout the entire arterial tree. These tears of blood vessels commonly occur without any prior dilatation. So we have no warning, no knowledge as to when surgical intervention might be protective. So we went on to make knock-in mouse models of vascular Ehlers-Danlos syndrome. Both of them have glycine substitutions in the collagenous domain of type 3 collagen. As you know, glycine at every third position in the collagenous domain is needed for the proper formation of the triple helix of fibrillar collagen. Both of these mouse lines show significant spontaneous death due to vascular dissection, here shown with a descending aortic dissection. Every mouse that has died has had documented hemothorax showing that it indeed died from aortic dissection. We do see a clear signature for increased ERK signaling in our vascular EDS mice without any signature for increased TGF-beta activity. So there are important differences, but also similarities. And the ERK antagonist in early studies has shown the ability to substantially protect these mice from aortic dissection. Pregnancy-associated aortic dissection is really common in these mouse models, and you can see if you simply remove the pups and prevent lactation, you now see 100% protection from pregnancy-associated dissection. Once again, the ERK inhibitor protects from pregnancy-associated aortic dissection in this mouse model. There was one report in JAMA suggesting that a specific beta blocker called celiprolol is protective in vascular EDS. It was a very small study that was not controlled in a number of ways, but patients are really desperate to receive this therapy. We can show in both mouse models that celiprolol unequivocally accelerates death due to aortic dissection in the vascular EDS mice. And curiously, for the first time, losartan is not protective in this model. It doesn't aggravate the disease, but it's also not protective. We can show that hydralazine is very remarkably protective. But very interestingly, this protection wanes right at the time of sexual maturity. It's much more exaggerated in male vascular EDS mice than females. This is exactly what's seen in people with vascular EDS, this sexual dimorphism with the early death of young men around the time of puberty. So now we're focusing on exploring a potential role for androgen signaling in this recurrence of dissection in mice that are protected up until that point. What we're most excited about is the genetic modification of vascular EDS. In both our mild model and our very severe model, now if you put the mutation on the 129 background, the background that was detrimental in Marfan syndrome, it's dramatically protective in vascular EDS, with the mice living out to, getting close to a fully normal mouse lifespan. In fact, even in the severe mouse model of vascular EDS on the 129 background, ERK signaling is completely normalized. All the expression profiling changes in the aortic wall are completely normalized. So nature has found a strategy to beat vascular Ehlers-Danlos syndrome, even with a severe mutation. We're very aggressively attempting to map that modifier. So we think an abundance of clinical observation-driven hypotheses and unbiased inquiry have greatly informed our mechanistic understanding. We think that there are now a large number of promising therapeutic strategies, including a number of FDA-approved drugs, and also including agents that are in clinical development. I'd like to end by acknowledging the truly remarkable young people that I have the privilege of working with every day. They are truly exceptional. I'd like to acknowledge my colleagues at Johns Hopkins and at other institutions that have made important contributions, and also my funding sources. I really thank you for your attention, and I'd be happy to answer questions. Thank you. Yes.
Saying that you were able to identify the mouse modifiers. And I feel like there must be a good story there, because if you had first made your Marfan model on Black 6, you might not have seen a phenotype. So how were you lucky enough not to do that?
So actually, we were not all that lucky. So we did first go to Black 6. We had to wait a long time to see the subtle phenotype emerge. In a way that was fortunate, because it allowed us to find provocations that made the aneurysm worse, like the calcium channel blocker. That would not have been possible on the 129 background. So it was a trade-off. But I think that we've clearly learned the lesson that when you make a new mouse, the best idea is to put it on a few different backgrounds early on, and then choose the one that best helps you address your question at hand. Yeah.
That was a terrific talk. The TGF-beta, is the TGF-beta effect all local, do you think, in Marfan's, or is it systemic? Can you see differences in plasma levels of TGF-beta, or is it all just a local effect?
Yeah, so if you, Jenny Van Eyck and a few other people have looked at circulating TGF-beta levels. They are subtly elevated if you look at large populations. For any one given individual, you might see complete overlap between controls and people with Marfan syndrome, but as a population, it's slightly shifted upward. I think from a signaling standpoint, from a tissue standpoint, it's all local. And in fact, in a paper that was just accepted yesterday, we've worked out why mutations causing Loeys-Dietz syndrome that you'd predict would cause a decrease in TGF-beta signaling actually cause an increase in signaling, and what the basis for that paradox is. And it's a local paracrine interaction between vascular smooth muscle cells of different embryonic origin that abut each other, that interface in the aortic root. So second heart field cells show a collapse in signaling. That leads by a variety of events that include the AT1 receptor to overexpression of TGF-beta 1 the neighboring cardiac neural crest-derived vascular smooth muscle cells couldn't care less that they have a Loeys-Dietz mutation. They're just signaling just like normal, but now they're bathed in a very high TGF-beta environment. So it's actually a local paracrine overdrive that's essential to create the aneurysm.
That's really interesting. Well, just one other question. The oxytocin story is really very interesting. Is there any clinical data in humans for breastfeeding association with in both Loeys-Dietz and Marfan's, or EDS for that matter?
Yeah, so that's a great question. Jen Habashi and Melissa Russo, who's an obstetrician, are currently trying to approach that from an epidemiologic perspective. They've sent out questionnaires. They've started to get responses back. Even with only 70 responses so far, they already see a significant finding that the women who have postnatal dissection are invariably breastfeeding. So it's giving early indications that there's going to be a signal there.
Hi, Hal. Good to see you. So we had the same finding, just a comment about your last comment. The smooth muscle cells from different lineage, second heart field and neurocrest stem cells, have different response to TGF-beta. And the second heart field smooth muscle cells need TGF-beta to differentiate, mature. And if this pathway, like TGF-beta pathway mutation, the signal is not enough, it will stimulate the cells to secrete more TGF-beta. Neurocrest stem cells differentiate smooth muscle cells. On the other hand, we do not need the chronic pathway to differentiate from our iPS cell model. Now, I talked to Elena at the Gentech Summit. We are so excited to know our results. We actually consistent. You're using mouse model, I'm using iPS cell model. They're actually almost exactly the same results. It's very exciting. My question for you is, the p-ERK seems like the driver of the aneurysm dissection. What's the downstream signaling? And everything stopped at your talk is at the p-ERK. Increasing p-ERK is bad. How does it cause aneurysm and dissection?
Yeah, so that's a great question. So we keep kicking the can down the road. We learned something more, but what actually culminates in an aneurysm remains an open question. One of the TGF-beta target genes that is invariably upregulated by ERK is MMP9. So there is some experimental evidence that matrix metalloproteinases 2 or 9 that are both induced by TGF-beta can contribute to degradation of the matrix and arterial wall failure. I don't think that that's the whole story. In fact, we now have direct evidence that ERK is both downstream of TGF-beta and upstream of TGF-beta, in that the high ERK signaling is needed to drive the TGF-beta 1 production that's overstimulating the neural crest-derived cells. So it's a very complex feed-forward loop, the TGF-beta driving ERK and ERK driving TGF-beta. We're pretty confident that that's also part of the story.
Can you comment on the optimal time window for administration of losartan in the human trials, and any speculation about the timing for cardiovascular purposes with respect to possible improvement of the skeletal abnormalities that occur?
Yeah, so with regard to timing, every trial that's been done has come to the same conclusion that the earlier the medication is started, the better the response. That is true of the Pediatric Heart Network trial. It's true of this new trial. So our practice is to start medication at the time of diagnosis. If a child has aortic root enlargement, it just makes sense to start. If a child doesn't have aortic root enlargement but has a family member with clinically significant aortic root enlargement, or has a mutation previously associated with aortic enlargement, given the excellent tolerance, we would say, yeah, it's okay, it's good to get the medication started even in a prophylactic way. So if somebody has borderline aortic root enlargement, we don't know what their mutation is, we don't have any family history, we probably would allow their aorta to declare its intentions before starting medication, get to a z-score greater than 3, for example.
And any expected benefit for the skeletal abnormalities?
Yeah, so in the mouse models, we did see a slight reduction in long bone growth rate. It was very subtle. The mouse is not a great model to look at long bone overgrowth. Largely, the phenotype is restricted to the ribs in the mouse. In the trials with Marfan syndrome, there is some effort to try to capture that, but so far, no dramatic signal. So not clear. I don't even know that the AT1 receptor is expressed in the relevant cell type. So that may be the story. Yes? Yeah, so there are so-called ALK5 inhibitors. They inhibit the type 1 receptor subunit, which is responsible for activating the SMAD cascade. There have been a number of studies for a number of indications trying ALK5 inhibitors, and they've all come up with pretty much the same story, that not only are there tolerance issues, but there's also paradoxical enhancement of TGF-beta signaling. So, for example, there was a Lilly ALK5 inhibitor that was tried, went into phase 1 clinical trials, and showed progressive fibrosis of the mitral valve that was deemed significant, and therefore it was not pursued. TGF-beta has an uncanny ability to find workarounds if you try to block proximally in the cascade. So we're more intrigued by the prospect of finding vulnerable spots downstream of TGF-beta to try to address. Yes? I'm sorry, how about? Yeah, so we have tried mineralocorticoid receptor antagonists and have not seen worsening or benefit. So we have yet to see any evidence that they have an impact. All right, thank you so much.